We have some time left for discussion, so I'd like to open the floor up for any questions to the speakers. I would ask you to speak loudly and clearly so that the entire room can hear you. Please identify whether the question is for a specific panelist or if it's for anyone to answer. So are there any questions currently? Yes.
Can I make a statement? I'm also a prostate cancer survivor, and my story is very similar to Bernard's, but it's kind of different.
Sure, yeah, come right up.
I'm Tony Goodman. I'm also a Library of Congress employee. My testimony and story is totally different from Bernard's. I had went to see my doctor because I was having shortness of breath as I walked up my stairs in my house. And so the nurse practitioner waited on me, and she was very thorough. She did a PSA test as well as other tests, and it came back showing particular results. My PSA had went from 1.9 to 2.8 in a year's time. So she recommended I go to a urologist, so I did. And when I went to the urologist, he said, well, I don't think you have cancer, but I'm very proactive, so I want to schedule a biopsy for you. So he did it about 2 or 3 months later, and the results showed that one tissue core was 85% malignant out of the 11 or 12 tissue samples that he took. So I went on active surveillance for about 2 or 3 years, basically just monitoring my PSA. And so about the 3rd year, other cores became malignant and stuff. So I decided to have my prostate taken out. And this has been about 2.5 years or so ago. So I'm totally cancer-free. And so I've been telling friends, everybody, males that I come in contact with, go to your doctor, get your PSA done, make sure. Because I've dealt with cancer personally, I'm cancer-free, but I've also had members of my family that have had prostate cancer, as well as other types of cancer. So it's a serious thing, and it shouldn't be taken lightly. And I'm speaking to the males, more so who don't want to go to doctors and have annual physicals and things of that nature. But my question for anybody on the panel is, I know now there's I think a thing now that's coming out dealing with proton therapy. So what is that all about in relation to treating people with prostate cancer?
So proton therapy is another form of external beam radiation. It uses a different type of particle, a proton, as opposed to some of the other particles that we use. And there's some notion that proton therapy may be a little bit more, that you can target it a little bit better. But the data regarding proton therapy is actually pretty controversial. There's really no evidence that proton therapy is of substantive advantage in terms of complication rate or survival compared to conventional forms of therapy. Really, the issue facing us is not how to treat prostate cancer, because we've got lots of treatment. You had surgery, you had CyberKnife, you had external beam, we have an expert on robotic surgery. Once we find the prostate cancer, we've got a lot of options. What's happening is that men are being denied the opportunity to know what's going on in their own bodies. Let's be completely blunt. What the USPSTF said is that a man does not have the right to know what's going on in their own body. That we say that if you get a PSA, as Dr. Ginzburg said, you may decide to get a biopsy. And if you get a biopsy, you may have cancer. And if you have cancer, you may opt for a cancer therapy that you didn't need, which is 4 decision points down, 3-4 decision points down the road. So because we don't trust you to make the best decision with your doctor for your own health care, we are going to take away the right for you to know what's happening in your body. And I know that this sounds Orwellian in nature and hard to imagine, but this is literally what the circumstances are. And so what we're talking about doing is just simply giving, a PSA is just a piece of information that is used to discuss with your family, with a man's family and with his doctor, whether or not a biopsy or other intervention is warranted. And that's really what this is about. These stories, we see it every single day, both of us, every single day. Men that would not be here without the PSA testing. Yeah.
Anyone else on the panel want to say anything on that?
I would just add to that I think that the USPSTF missed or ignored what our last speaker just discussed, and that is the role of active surveillance. Elevated PSA doesn't mean an operation or treatment. An elevated PSA, as Dr. Kapoor just mentioned, gets you to the next decision point. But even if a biopsy comes back positive for prostate cancer and is confirmed with D-spot testing, DNA testing that belongs to that patient still may enter an active surveillance program where a lower grade cancer, lower volume cancer will be observed to watch for its biological activity with repeat biopsies to determine whether or not that patient needs to move on to definitive therapy or not. And they completely, again, missed or ignored the standard of care, because what you described was exactly the standard of care. Thank you.
Just a few more comments, specifically on your question about proton therapy. So it's an analog of radiation therapy, and it's significantly more costly than traditional radiation therapy. There's only very few centers in the country that administer proton therapy. It only has short-term results and no significant proven benefits. So I second Dr. Kapoor's opinion on that. Another point I want to emphasize, hearing these two anecdotal stories about prostate cancer experiences, is that both of the members that spoke are members of the African American community, where prostate cancer is a lot more prevalent. It's 60% more common in the African American community and 2.5 times more lethal. And it's important to recognize that. Additionally, these men experienced prostate cancer, are survivors, but their children are at risk. So we need to make sure that people at risk have the ability to screen themselves. Thank you.
Other questions? Yes.
Open question for the panel. Since we are in halls of Congress and prices gets brought up a lot, what's the cost of a PSA test?
Just to say that out loud for everybody to hear, someone just asked, what is the cost of the PSA test?
The cost of it really depends on the lab and the region, but typically I guess it would cost somewhere around $40 to $60. I guess is about the cost. But the issue is that $40 to $60 to somebody that is a earner and all that may not necessarily be a big deal. They pay out of pocket. And the thing, what was mentioned earlier is that here in Congress, what was fascinating to me is that the USPSTF, which is a part of the administration, indirectly, of course, but issued a recommendation that no man should get PSA testing, and literally 1 week later, during his annual physical, President Obama got a PSA done. And so my view is, if it's good enough for the President of the United States, it's good enough for everybody else, because the risk is that if the Secretary acts to cut the benefit, and there are commissioners on MedPAC that are making that recommendation, that $60 for a person on a fixed income is a lot of money. And they won't get the testing. And we're seeing that it's just not being ordered on a routine basis by the primary care physicians. And that's really the tragedy. We heard two really uplifting, heartwarming stories. I'll tell you a converse. I had a gentleman that came in my office yesterday. He was an electrician. He lives in Massapequa, New York. Not going to win a Nobel Prize, okay? He's just a salt of the earth kind of guy. Came in, he was one of the guys that was a first responder in the electrical unit at Ground Zero, was exposed to a lot of toxins, has had 3 cancers since that time. His doctor stopped doing PSA testing in 2010. He presented with 10 cores of Gleason 10 disease that is metastatic in his entire body, And I just had this conversation. Yesterday was one of the worst days I've had. He's 53 years old. And he said to me, "Doc, you've been my doctor, my family's doctors for years. I have complete confidence in you. You're going to take care of me. You're going to cure this, right?" And I have to look that poor man in the eye and say, "No, I'm not going to cure this."
And in my case, you're talking about price, and I was talking about the health fair being an on-ramp. We provide for free PSA screens. I mean, it's a part of the attraction to get men to come to the health fair. Once you're at the health fair, and most urologists say that, men would come in to check their prostate, and we'd find other issues, health issues in their life. But at the health screens, we were doing free screens, and really men were coming in the droves because they wanted to know, they wanted to find out. And largely this audience were uninsured or underinsured. And as a health system, we were providing it for free. But once the ruling came in, we could no longer offer it. And soon as the word got out that we were not doing it, then the attendance or the on-ramp for men to be able to take the snapshot of their health was no longer available. So The ruling has had major impact on men's ability to get in, and men's interest in wanting to get in, and the obstacles in the way.
I'm just curious, why couldn't you offer it anymore?
Because the ruling said that we could not do it. The recommendation said that offering, and I'm gonna let these guys,
Funding supplied by like a government organization?
government organizations, right?
So in our case, we have, as part of our commitment to our communities, and we have 1.45 million active charts, which is about 10% of the entire New York metro area. He's one of our doctors. So we set up our own not-for-profit foundation, and we generate independent funding that largely comes from our own doctors. And we continue to do screening, and we continue to do PSAs.
Right.
Problem is, nobody comes. You know, they get the thing and say, well, okay, the government said, you know, I don't wanna get overly colorful, but there's more to a screening than just a blood test. And
Right.
if somebody can avoid certain aspects of the testing, they just don't wanna come in. So we continue to offer it, but people just say they got an excuse not to come because, oh, the government tells me I don't need this anymore. And so, and if anybody's interested, I don't wanna get into the weeds on it, but it's astonishing how the USPSTF could have been so wrong in terms of their analysis of the data. It's stunning to position, as you saw, urologists don't react to it because our analysis of the data is completely different than theirs is, and it shouldn't be a fight among scientists.
But Dr. Kapoor, you said something very interesting. You said very bluntly that it just seems to say that we don't want you to know. And I, you know, again, I'm not a conspiracy theorist, but I hear and I understand what you're saying. But I wonder what, and this is a tough question, what is being protected? Why would we not want you to know? Is it you're protecting from the abuse that could happen in the industry? What is it, in your opinion?
It's an interesting question, but I can't even speculate to it because we can't ask the USPSTF. They're exempt from the Sunshine Act. They're exempt from the Administrative Procedures Act. They're the only entity in the government that has the ability to set payment that are exempt. We don't have the right to ask how they came up with it. And that's why this bill really is just so important, to establish a level playing field, the same standard to an entity that has the ability to reach so profoundly into the lives of Americans, not just American men, because they make recommendations on all screening services, whether it be mammograms or colonoscopies or whatever else it is that they're making recommendations on. They have an unprecedented reach into the lives of people. And it's just simply granting the Americans the right to know.
A quick comment on the cost of PSA screening. I think the relative cost of PSA screening relative to the care that is required in the future is negligible. And there are mechanisms in place, grants. For example, we have a grant from the Foundation for Breast and Prostate Cancer to screen men in our urban community in Philadelphia. So we can get the test out there to the men. The issue is the Preventive Task Force recommendation discourages the physicians to order it. So it's not the financial barrier per se that is blocking PSA screening, it's the discouragement of the physicians to order it, and that's the bigger barrier.
Okay, we had a question here first.
Yeah, I'm Arnie Owens with Senator Bitter. We went through all this last year with breast cancer screening. And the task force issued its draft recommendations and their final recommendations earlier this year. Where are we in the actual process of releasing a final recommendation from the task force? I mean, your paper here says it's going to be released next year, so presumably there's going to be a draft recommendation in the end of this year. They've got the research plan now. We provided input to that. Where are we in all of that?
Well, we don't know. Again, they don't tell us a lot of this stuff. So what happened, I think, and I'll be a little colloquial here, that I think somebody in the USPSTF, with the way the trends are really, kind of realized that somebody may have screwed the pooch a bit on this one. Because for them to re-ask for a research plan so soon after issuing a final recommendation is really pretty unusual. So what, based on the overwhelming negative feedback and some of the adverse trends that we've seen, they've asked for a research plan to be put forward to reevaluate the question of screening. When that's going to happen, we can't say. But
again, we're going to have the same issue as we had before, because once they're still not including specialists in terms of the decision-making process. They're still not transparent in terms of how they're evaluating the data. So unless we change the process, we may wind up exactly the same way. And in the interim, whether it takes them 1 year, 2 years, or 3 years, what is the human cost between now and then? Because one component of this is that of this bill is that the secretary cannot deny payment policy based on the grade D recommendation, at least in terms of PSA screening. That's something that we need to have now, not 2 or 3 years from now when they revise the recommendation.
In the back, please.
So I'm 23. Well, at that age when most men think that they're still invincible, and it usually takes a wake-up call, like what happened. My sister's 27. She's diagnosed with breast cancer this past March, and they found through testing that she had a mutation in the BRCA1 gene. And for me, that was kind of a wake-up call to start getting tested for things. But what age would you recommend that men start getting a PSA testing?
Well, there's as many different recommendations as Dr. Ginzburg said. Everybody recommends PSA screening except for the USPSTF, which the only thing I would say is they're not even a medical, you said medical society, they're not even a medical society. So everybody that's actually taking care of patients recommends screening. What the amalgam recommendation, and there was a consensus guideline that came out of a group in Australia, is based on what we know now about PSA trends. Depending on your relative risk factor, you get a baseline PSA, unless you have some unusual risk. You get a baseline PSA sometime in your 40s. And based on that baseline, you can determine what your follow-up is. We know that if your baseline PSA in your 40s is very, very low, your lifetime risk of developing prostate cancer is reasonably nominal. So if you have a PSA, it comes back at 0.2, maybe you don't need to get another one for 10 years. But if you have one that's a little bit higher, or if you're in a risk population, one of our veterans that's been exposed to Agent Orange or Ground Zero, African American men, people with a family history, then perhaps you set up a customized screening thing. Right now, it's not one size fits all, like USPSTF said. You get a baseline, you talk to your doctor, based on your own baseline score and your own risk factors, you should have a screening regimen that's customized for you. Your risk with the family history, with your genetic, with the genetic abnormality that's there, is going to be decidedly distant than my risk or Serge's risk or anybody else's risk in the room. So it's important to have a customized regimen, but the thing is to have access to that testing.
Excellent, fully agree. In your specific case, you have BRCA1 mutation, as you know, both BRCA1 and BRCA2 mutations in first-degree relatives confer a significant risk of increased prostate cancer, specifically BRCA2 high-risk prostate cancer. So absolutely, you should get screened earlier than an average man. So at least around the age of 40.
We have time for one more question.
There was I think this gentleman had.
I believe it was asked and
Okay.
answered.
Okay. Anybody else? Saw one over here.
But I do have one quick question. You talk a bit about the transparency and how the ruling is a bit of a head scratcher. Is there any legal standard, at least, that the PSTF puts out in terms of, because it sounds like you don't know what the decisional factors are, how they're weighted. Is that an accurate?
Yeah, to a point. So, basically the problem, there's no urologist that believes that the screening recommendation should have been an A or a B, because the data on screening is very confused and there isn't any study that's really good. We've got a lot of epidemiological data that's pretty vague. What seems to have happened is that the USPSTF weighted a study called the PLCO study, as opposed to another study called the ERS. I don't want to get into the study alphabet soup that was there, but there are two big studies that directly contradict each other. The problem with and they're both flawed. So most urologists believe that since both studies were flawed and it was contradictory, we should get a C recommendation, which is we just don't know yet, it needs further study. But what the PLCO to give you an idea, and I asked this question, I'm going to ask it to the room, okay? So if you were going to design a study to evaluate PSA screening, the effect of a screening test, you would say, on one hand, I would screen patients, and the other hand, I set out, you wouldn't screen people. But the PLCO study didn't do that. The PLCO study said, we're going to compare screening against something called usual therapy. Because in the United States, PSA testing was fairly ubiquitous. And so what it turns out, that in the original publication, which the USPSTF hinged its recommendation on, you had one group of patients that got screened, and another group of patients that got screened 55% of the time. So you compared screening against 55% screening. And go figure, you didn't see that much of a difference compared to the European study, which was very dramatic. What we just recently found out, just in June of this year, and we can supply that literature, is that the data contamination in the control group in PLCO wasn't 55%, it was 90%. So the USPSTF hinged it, and we don't know how they weighted it, because they don't tell you, they just say that we looked at these studies. They based this decision that's affecting the lives of tens of thousands of men on a study that compared screening against 90% screening. Which is why, when Serge and I look at the data, we don't come to the same conclusion as people that never treat prostate cancer, because we say, this just doesn't make any sense. You can't make a decision on this. Which is why you need to have experts on the field, people that take care of cancer, people that are involved in the disease, helping the epidemiologists understand the numbers that they're looking at.
Yep, fully agree. Additionally, they looked at the benefits of screening and they balanced them against the harms of treatment. Well, the harms of treatment comparison is historic, right? Because they consider patients that would have basically non-aggressive, nuisance type rather than a risk type prostate cancer, and those patients undergoing aggressive treatment. That's hardly ever done anymore. Over 50% of patients with low-risk prostate cancer are no longer treated aggressively. They're on approach that this man has undergone, which is active surveillance, where you simply closely monitor the disease. So you are improving your screening with these new technologies, multiparametric MRI, genomics, proteomics. You're improving your screening value, and you're decreasing the morbidity of the treatment. So both things are working in favor of offering screening, whereas they kind of took the worst view of the screening and amplified the morbidity of the treatment, which is no longer applicable in the modern treatment of prostate cancer.
Any final words from Dr. Knapp or Mr. Sabbs?
The only thing I would add is that also looking at the different studies that have been referenced, the prostate cancer, there are a significant percentage of prostate cancers that are slow growing. They take a time to develop and affect the patient's life and health. And the initial studies that were looked at were younger studies. They're looking at 7 and 8 years of data. Studies that were the European studies looking a little longer at 10, 12, 14 years of follow-up. You start to really see the benefit of PSA screening. So that data hopefully would be looked at more accurately. Previously, again, was either missed or ignored. There was a significant difference.
All right, great. If we can give a round of applause to our panelists, please. Thank you all for joining us. Also want to thank our partners from the Foundation of Breast and Prostate Health, and also our friends who are present today from Zero, the American Urological Association, and LUGPA, who share in our concern about identifying prostate cancer and providing appropriate treatments if needed. So
can I thank Men's Health Network for their undying commitment to this issue. And it's because of that kind of advocacy that we're able to even have this discussion. So thank you so much.
Thank you, Darrell. Once again, we want to thank our congressional sponsors from the Men's Health Caucus, Congressman Markwayne Mullin and Congressman Payne Jr. and their offices. And thank you all in the audience for coming and sharing in this topic and asking your questions and participating. Have a wonderful day.